Well, I want to start by saying good afternoon to you guys. This is literally the last event of the day, right? The last event of the conference. So, I am so impressed, I have to say, by everything that this conference has been. I mean, so many people, so many wonderful sessions, but I'm also so impressed by the people that I've met and all the students and people who've been willing to share with me their stories so far. And so I just want to really thank the organizers once again for putting this wonderful conference together and also for getting all of us together in this kind of supportive and open community to be able to talk about so many things. And I'm grateful to all of you for sticking around until the end of the day. So what I want to do today first is to introduce myself, and then I'll talk about the art of the patient narrative. So my name is Leana, and I am an emergency physician at George Washington University, where I'm also the director of patient-centered care research. And patient-centered care research is a broad term, but basically it means how can we redesign the healthcare system to really respect patients' dignity, human dignity, and not just to do what's good for doctors or good for administrators. But I'm also a writer. And a lot of the work that I do is on figuring out how can we write for patients and how can we write to communicate stories of our patients to other doctors and other healthcare professionals. And my book, When Doctors Don't Listen, which Diana over there has been very nice to assist with distributing during this conference, talks about better methods for patient-doctor communication. And I'll be talking a bit about that, but today what I really want to emphasize is the art of the patient narrative. And I start with the patient first and foremost because this is really why we're all here today, right? I've been saying during these other sessions that if you know that you'll be just as happy being a doctor as you are being a researcher, or just as happy being a nurse as you are being a journalist, then you're better off doing the other thing. Because medicine and the health professions, it's a hard process. It takes a long time to get through, but it's also something that is really time consuming. It's all consuming, in fact, for you. And so it's so important to really identify what your mission is and be focused on the patient first and foremost. And I want to talk about how the narrative, the story, can be used to enhance your diagnosis and improve patient care, but also how it can be important in transforming policy, how you can use it in advocacy. And I'll use the term advocacy here quite broadly, but what I mean by advocacy also involves advocacy for yourself. When you're applying to medical school, when you're applying to PA school or public health school, whatever the case might be, you're also advocating for yourself, right? You're saying, this is why you should accept me over other candidates. This is why I belong at your school. Part of that is also telling your story. And so I want to, hopefully this will cover all of these different subjects as well. And so in my talk, first of all, I'll be talking about why we need narrative, why narrative is important, right? Because before I convince you, you should care about it, you should first know what it is and why it's important to you. But then I want to show you how it could be important in clinical care and how it could be important in your advocacy work. Then I'll give you 8 tips, 3 tips on how to get the story, because you have to get the story before you tell it. But then 5 tips also on communicating the story, whether it's your own story or your patient's story, or another story that you do as part of your advocacy work. And then I'll end with the lessons learned. So what is the talk about narrative without some stories in itself? And so what I want to do is to start with 3 stories. And I want you to keep them in mind as we go along, but also think about these stories from the perspective of being a healthcare professional. So think about if you were the doctor in this case, what would you do? Or if you were the medical student or the nursing student, what would you do? All right? Some of you have heard maybe one of the stories before, but bear with me for a second. So the first story is of a gentleman named Jerry. Jerry is a man in his 40s, works as a mechanic in South Boston, and he comes to the doctor because of some chest discomfort. But when you talk to him, it's not really chest discomfort. It's actually that he was moving boxes, maybe boxes of my heavy books, I don't know, but heavy boxes over the weekend. And he wakes up the next morning with this pull in his chest. But it's not just his chest. He's also having a pull in his back, in his arms, in his belly, in his legs. Basically, he has this discomfort all over his body. Now, we all know what this is, right? This is a muscle pull. He was moving boxes, he's sore all over, that's what he has. But he'd read that maybe anytime you have pain somewhere between your chest and your belly, or between your belly and your neck, you have to think about this being chest pain. And so he says, well, let me call my doctor. His doctor hears chest pain and immediately says, gotta go to the ER right now. And so he goes to the ER. Now, I'm an emergency physician, so lots of these stories are based in the ER, but Jerry shows up in the ER, and immediately the triage nurse says, oh, chest pain. And so hooks him up to a machine, gets an EKG, he gets a chest x-ray, he gets blood work done. He gets told that he has to stay the night to make sure that he didn't have a heart attack. So he says, all right, well, he's not going to argue with the doctor, right? So he stays the night. The next morning he wakes up, he gets more blood work done, more EKGs, another chest x-ray. He then runs on a treadmill. And at the end of all of that, he gets discharge paperwork that says he has chest pain. So he says, well, I want to speak to my doctor. And the doctor comes in and says, well, the good news is you don't have a heart attack, you don't have pneumonia, you don't have rib fractures. And he says, well, what do I have? And the doctor says, well, you have chest pain. But isn't that what he knew? Didn't he know he had chest pain when he went in to see his doctor? So what was the purpose of going? Why is he leaving the doctor with more questions than answers? I mean, how is he going to feel better? He doesn't even know, should I go back to work? Am I going to die or am I going to be fine, right? That's pretty different. So a few weeks later, he gets this chest discomfort again. And this time he goes back to see his doctor, and the doctor says, well, now we need to see, you need to see a specialist. And so he goes to see a cardiologist who recommends a catheterization, and so he gets a catheterization done looking at his heart vessels. He gets an endoscopy from a GI doctor to look to see whether his stomach and his esophagus look fine. And the good news from all of it is, it's great. His heart looks great. His heart vessels are clean. His stomach looks great. Esophagus looks brand new. But in the process of all of this, he ends up getting a perforation in the esophagus from the procedure. He has an aneurysm at the site where he had a catheterization. He gets a pneumonia. He gets a urinary tract infection. He ends up in the hospital for 2.5 weeks. Now, Jerry will tell you today, I feel lucky to be alive. But is he a recipient of good medical care? Or was he a victim of overtreatment and of what happens when the doctor doesn't listen? Okay, so I want to give you story number 2. Keep story number 1 in mind for the time being. Story number 2 is of a girl named Danielle. Now, Danielle is a college student. And maybe you'll relate to the story, some of you who are a bit younger. Let's say that she's 21 for the purposes of the story. So her roommate's 21st birthday is happening, and they go out drinking. And she has a few too many shots or beer or wine or whatever the case might be. And she wakes up the next morning with this pounding, splitting headache. Her mouth is dry, she feels lightheaded. You don't have to admit to it, but I'm sure that all of you know in some way that this is a hangover headache, right? And of course, you know, Danielle is pretty sure this is a hangover as well. Her roommate also looks like her, and they both don't feel well. But she's not really drinking very much. She calls her mom. Mom gets worried and says, well, student health is closed, so go to the ER to get checked out. Now, she tells somebody in the ER, we don't know who, maybe it's a triage nurse, maybe it's the first doctor that sees her, whoever, that she has the worst headache of her life. Now, I would say, well, all of us at some point in our lives, or at least we'll have one episode of the worst headache of our lives, right, by definition. But when you hear that, immediately this triggers this, this avalanche of stuff happening. First, the doctor says, we need to get a CAT scan to make sure you don't have a bleed in your head. Then somebody else comes in and says, here's the consent form, we have to do a spinal tap. At this point, Danielle is terrified. I mean, she actually thinks she's fine. She's feeling better. She wants to go home. But now the doctors are saying, if you go home, you might die. So you know what she does? She goes to the bathroom. She takes off her hospital gown. She takes off all the leads on her chest, rips out her own IV. So there's this pool of blood on the ground. She goes to the window, opens the window, and jumps out the window. Now, it's a first floor window. I was telling this story the other day, and I left out the part about the first floor window. People thought that she committed suicide, so it's not quite that dramatic, right? But, but it's not, this is not ideal. I mean, she jumped down, and maybe one could even argue she avoided unnecessary testing and unnecessary harms. But our medical system should not be such that we make our patients feel so trapped that they literally have to jump out the window. That's not good medical care. So I'm going to give you story number 3, which I think is a balancing act to the first 2 stories. And so this is of a woman named Sandy. She's in her early 40s, and she is a school teacher in Los Angeles. And she goes to the doctor because of several weeks of not feeling well. She's feeling run down, she feels tired, she has a cough that just wouldn't really go away, feels a bit short of breath. And her doctor takes one look at her and says, middle-aged woman, nothing really much going on, you'll be fine. She never goes to see the doctor, and so she knows there's something wrong, but she doesn't know how to say to her doctor there's something wrong, and so she says, all right, maybe I just have a virus, I'll go home. A few weeks later, she comes back to the doctor. No better, if anything, only a little bit worse. And the doctor says, fine, this time we'll do some tests. Now, we're not sure what the doctor did, but let's say that he looked at her blood work and checked to make sure she didn't have anemia or hypothyroid, or maybe did a chest x-ray, and tells her at the end of all of this, you're fine. Everything's negative, go home. Now, she still doesn't know what's going on. And the doctor says, well, if you really want something, how about some Prozac? Maybe you're depressed. So she says, she doesn't really want to argue with the doctor, right? She was raised in this time when your doctor's almost like your parent. You don't want to tell your doctor you're wrong. She's afraid of being the bad patient. And so she says, all right, I'll try it. Doesn't get better in a few weeks. Goes back, and now she sees the doctor's partner who sees the previous records of, now she's on antidepressants and says, well, now you're just anxious. Go home and take some Valium. This repeats and repeats. And it's not until about a year later that she's finally diagnosed with breast cancer that by that point had spread to her liver, to her bones, to her brain, and into her lungs. And I tell this story because of all the things that we talk about when it comes to overtreatment and the harms of overtreatment. Let's not forget that there's a significant harm when you also get the wrong tests. Like some people will raise their hands and say, well, isn't this the opposite of Jerry and Danielle? Shouldn't she have gotten more tests? Well, I would say that tests are not the answer. She did get some tests, remember? And what if she'd gotten the same test that Jerry had? What if she had an EKG and things looking at her heart or an endoscopy? She still would have been found to have nothing. But the problem in this case was not that she didn't get enough tests. It's that she didn't get the right tests. And also that she was never listened to. And not listening could lead to even bigger problems than too many tests. It could also lead to misdiagnosis. Every year, 100,000 people die because of medical error, and the number one cause of medical error is misdiagnosis. So that's another reason why listening is so important. Now I want to take a step back and talk about an experience that I had that really changed my life in medicine. So for those of you who went to the Leadership in Medicine talk earlier, I spoke about how you have to have your mission in mind, but there could be a lot of different tracks. I welcome you guys to ask questions, but the one question that I hate being asked and that I encourage you not to ask, if at all possible, is how did you get X? Like, how did you get this position, or how did you get this? Because I don't think anybody should plan to do X. You shouldn't plan and say, I'm going to be whatever, I'm going to have this position, I'm going to work for the WHO, I'm going to work for whatever, because you should think about what I should do, what I can do in this position that really appeals to me. What can I get done? What is my mission that I'm here to serve? And so I never really planned for this, but I ended up working as a journalist. And I was fortunate to work with Nick Kristof from the New York Times. This was back in 2006. So he's a Pulitzer Prize-winning columnist. And I was fortunate to travel with him throughout Eastern Africa and to learn from him about his reporting and listening techniques. And I'll say that he is a master when it comes to really listening and drawing out the story. This is us interviewing this general in the left of the picture is this famous warlord who had killed hundreds of thousands of people. And this is us interviewing him about what is it like? Will he tell the truth? It's a very daunting but very powerful experience of what happens when you're really there to listen to the story. We were also part of this movie called Reporter that's on HBO for those of you who are interested as well. But one thing that Nick taught me is the importance of persistence. Just because somebody doesn't want to tell you the story initially doesn't mean that it's not there. We would go to these villages because at that time we were looking for what happens in conflict, right? And we were looking for the human side of war. We were in the Congo, which was in the middle of this huge armed conflict, still is. But so we were looking, and we would go to a village, and he would say to someone, "Well, has anybody here been killed as a result of the conflict?" And they would say, "Well, not in this village, but in the village over there, somebody was killed there." And you know what he would say? "All right, let's go there." Which is not a normal instinct, right? Normally, if somebody says people got killed there, you would say, I'm going that way. But for him, that was how persistent he was, because that was important to him to get the story and share it. Because in sharing the story, that's how we can make a difference. That's how we can convince people that this is a war that we have to really care about. And so one of the things that he wrote about was the human cost of war. And we were going around to villages trying to identify, it's not just people who are getting killed from the war itself, but it's also people getting killed as a result of starvation, as a result of other things. And we found this woman, Joanita, in this village. And what had happened was this woman, she was part of a pretty prosperous farming family. And they had lots of crops. They were actually doing one of the wealthiest people in their village. But then the rebels came and took everything. So they grew everything back. Then the government soldiers came and took everything. Then the rebels came and burned everything down. So they literally had nothing in their village. And so she, being a woman, she gave all the food to her husband, to her elderly parents, to her children. and she literally was starving to death. By the time that we found her, she weighed about 50 pounds. And that was the human cost of war, right? That it's not just somebody getting murdered directly, but it's also these people dying slowly as a result of war. And so I also mentioned this in the setting of advocacy. There's something called the Rokia experiment. For those of you who haven't heard, it's asking people, well, who would you give money to? So think about it. Would you give money to a 7-year-old girl named Rokia, who's a starving girl in Mali? Would you give money to 21 million starving Africans? Or would you give money to Rokia, but in the tapestry of 21 million starving Africans? Well, the answer that nearly everyone gives is that they would give to Rokia, because they're moved by one person, almost that we have the psychic numbing. When we see too much, we can't relate to it. But when we see one person, one story, that's what we relate to. So Nick also wrote a column called Save the Darfur Puppy. And at that time, Darfur obviously was going through a lot with genocide and war and all these conflicts and people dying. He was so frustrated. He was there and seeing all this stuff was happening, but why weren't we paying attention? In the same issue as he was writing about Darfur and the civil war going on there, there was another article about a puppy that was stranded on a cruise ship. That one article and the picture that went with it was the most emailed, most viewed article of the week. And people got together and donated $57,000 to rescue this puppy from this cruise ship. And so Nick said, what about let's save the Darfur puppy? What if Darfur actually had cute, fluffy ears and we're prancing around? Would we care about this more? This is the dark side of human nature, right? That we don't care about things. But that's why, though, we have to turn to stories, because ultimately, we are helpless when you say all these thousands of people are getting killed, but we're moved by stories. So I want to tell you also about the why for narrative in clinical care. In clinical medicine, I often talk to medical students. I teach medical students, right? And sometimes some medical student will raise their hand and say, but I don't get it. That's not what we learn in medical school. We learn about asking questions. I don't really understand why we need to hear stories, right? And it's true, like in medicine, you do hear all of this about, let's say that somebody has chest pain. You then ask them, when did your pain start? Where did it radiate to? What made it better or worse? That's part of the history that you learn. Well, I think that is wrong. I'm sorry that I have strong opinions about things, but I do. I think this is the wrong way of teaching students. It's the wrong way of practicing medicine. Let me give you a thought exercise for why this is the case. Let's say that you haven't seen an old friend of yours for a long time. And now you're at this conference and you see them. The last time you saw them was in high school or something, and you have a junior high. And you haven't seen them, and now you run into them. You're like, hey, Jane, how are you, right? What are you up to? What have you been doing? That's probably what you would say. How are you? What if instead of doing that, you said, are you single? Are you married? Do you have children? Did you finish high school? Did you apply to medical school? Did you get in the first time? Did you can ask them all these questions and you'll get some kind of answers, but you won't get nearly the nuance or depth of answers as if you just asked them, what is your story? How are you? And you can think of that applying in clinical medicine as well, right? In the case of Jerry, people could ask him 20 questions about his chest pain, and all they'll get is that he has chest pain. But what if you just let him talk and he talked about the boxes he was moving? Or Danielle and all the and going to drink the night before. They'll get so much more depth by just asking the story, rather than saying, here are all the questions that I'm going to ask you instead. And so the narrative is important because it does avoid misdiagnosis and medical error. We know that the history is by far the most important test out there, that 80% of medical diagnoses can be made just based on the history alone. That's amazing. Tests, 1 test, 2 tests, 3,000 tests. You can do a full body MRI of me and do every living test known to mankind and sequence my DNA, but you're not going to get to my diagnosis as you would if you just listened to my story. And I find that to be really profound because we talk all the time about medical advances and how we're going to invest more in getting a better test or getting robots doing your surgeries and all these high-tech advances. But what about the most low-tech intervention of all, the story? Why are we forgetting that while getting these high-tech things? I'm not against science. I'm not saying don't do these other things, but rather let's not forget the art of medicine while we're at it as well. Also, we know that narrative builds trust. If the patient doesn't think that you heard their story, they're not really going to trust your recommendation either, right? They'll be like, well, you never heard what I'm saying, so why would I trust that the diagnosis is right? So trust is really important. And we know, too, that narrative is important in healing. If you're feeling bad about something, you talk to someone, you feel better. And we know this empirically too, that talking to your doctor actually lowers your blood pressure. Even that act releases endorphins that makes you feel better. And I'm not saying that that's all the doctor should do is listen to you and not do anything else, but rather that the act of listening is so much this therapeutic act too that has to take place. Now, why narrative is important in advocacy, I think, is fairly obvious. And I mean advocacy in the broadest sense, again, advocating for yourself, but also in everything else too. And narrative is so important, again, because we connect with stories. Think about the last time that you read about an NGO, right? An NGO is trying to convince you to donate money to them. They don't say, our operating budget is $3 million and we have sites in 20 different cities. I mean, that's pretty boring, right? You don't want to say that. Rather, this NGO, maybe they help children who are orphaned from HIV. And maybe they'll highlight this child who was orphaned at the age of 2 and now is in college. I mean, that is a story that people will take away. So think about how this is used in advocacy. It also allows us to put a human face to numbers. We can talk about gun control all the time, but then Congresswoman Gabby Giffords shows up and she says, look, I was shot. This is the impact of guns. And I don't know where you are on that spectrum, but no matter where you are on the political spectrum, this has a powerful effect on you. And then also people relate to stories. We were talking earlier about what drew us to do various things, right? I mean, and what drew me initially to do international work, because I never knew that I wanted to do international work. I did all this domestic work and I thought there are enough problems in the US. But then I read the story actually about Rwanda. This was back in 2003 and people were not really paying attention to rebuilding Rwanda yet at the time. And there was a story about how there were women who were raped as part of the Rwandan genocide. And they were raped because HIV was seen as a weapon. There were men who were HIV positive, who knew they were HIV positive, who were raping women in order to cause them a slow death. These men, many of them were in jail. They were getting access to antiretrovirals, but the women they raped were not, and neither were their children. And that story really struck me, and I was thinking, what a profound injustice. But it was that story that really drew me. That's why I got into international work, and I encourage you to find stories like that for yourself, because something has to draw you into the work, right? You have to really believe in your work. But also that kind of story is also what you relate to other people, because that's what draws them in too. And I would say too, that storytelling, you have to see this, we know that this is inherent as part of our culture. It's how we connect with each other. It's what inspires us. It's what empowers us. And also ultimately that we are selfish individuals. And so these stories also help to personalize things. And so if you are applying to medical school and you have all these, 20 accomplishments that you have and your MCAT score and whatever, admissions officers see that all the time. But when you make it personal and say, this is why I'm doing what I'm doing, this is who I am, this is my story, that's a lot more genuine, that's a lot more authentic. That's what people remember at the end of the day. And so I want to give you now 8 tips. So 3 tips on getting the story and 5 tips on telling the story. So in terms of getting the story, very important is to be open. Being open means you're listening with an open mind. Being open means you don't come in with a preconceived notion. You don't come in, you look at the person and say, well, they're fine. They should go home. But also, I would say that we need to be very, very careful in medicine of the chief complaint. I hate it when medical students come in or residents come in and they say, well, this person had 4 things that they're coming in for, so I made them choose 1. Why? I mean, that's like Sophie's choice right there, right? But also, if you're applying to medical school and they say, well, I don't care about all the things that you've done, just choose 1 thing that you've ever done to illustrate why you're in medicine. That's not fair and that's not right. And it's not good medical care. So let's say that somebody has the flu. They're aching, they have fever, they have a sore throat, they have a runny nose, they have a cough. If I ask them to pick 1 thing, I'm going to get their diagnosis wrong, right? So, and also what they initially say might not be the real diagnosis. And so keeping your mind open and don't just focus on the chief complaint, I think is actually really, really important. That's something that we often forget in medicine because we say, oh, we have limited time, we need to focus on 1 thing. And actually speaking of that, one of the things that I hear over and over from doctors is lack of time. And I work in the ER, which is probably about as stressful and as time limited of a situation as you can ever have. In an average 8-hour shift, I often see up to 60 patients, 60 patients. I mean, that's less than 6-7 minutes per patient. I mean, we know from studies that doctors will interrupt patients in something like 10 seconds. 10 seconds. Now think about how much of your story you can communicate in 10 seconds. Think about if you're at an admissions interview and the person says to you, you have 10 seconds to convince me why you should be here. That's pretty daunting, right? But your health is even more important. I mean, imagine if this person is uninsured, they have one shot at their healthcare, and you're giving them 10 seconds. Is that fair? Right? And so we know that that's not the right thing to do for medical care, but it's also not the right thing for the patient to get to their right story. And I actually would argue that my listening for an extra 30, 40 seconds will allow me to save a lot more time later, because otherwise I'll be ordering all kinds of tests, following up on tests, telling the patient about this test, telling them about the result, and still not knowing what's going on, versus if I listened, I would be able to get the right test. And so time is important, but keeping open is a big part of that too. Related to this, second tip is to listen, and really listen. So I was born in China. I never learned traditional Chinese medicine because I did all my medical training and formal education here. But a couple of years ago, I went back to China to do a project, and I was so amazed by these traditional Chinese doctors. I don't really understand much about Eastern medicine, so I won't claim to be an expert, except that the ones that I saw, the way that they interacted with patients, I found to be amazing. One of the doctors said to me that his philosophy of really listening to his patients is to listen with your whole being. And I find that to be really profound. You don't just listen with your ears, you don't just listen with your eyes, you also listen by indicating to them. It's a two-way street, right? You indicate to your patients that you really care, that you're there, you sit down, you're listening, you're only focused on them. But in return, you're also picking up every single cue that they have. Are they fidgeting? Are they looking nervous? How are they seeming? And what other things can you detect? What odors can you detect? What kind of anxiety can you detect? And I actually think that that's such an important part of diagnosis that we don't teach in medical school, we don't teach in PA school, we're just not doing a good job of this. Yet that intuition is so important for us to be able to develop and master. I also do an exercise with medical students called No Questions Asked, and it's exactly what it is, which is you should be able to get to the diagnosis by not asking any questions. And initially, people are really daunted by this, right? First-year medical students, I ask them to do this, and they're like, but I don't know what to do. I haven't even learned how to take a history. But actually, you know what? These first-year medical students who don't know how to take a history, without fail, they get a diagnosis. They get a history. And I actually think they do a much better job than third-year medical students, than residents. Because third-year medical students begin asking all kinds of questions that aren't needed, and residents don't even want to try this anymore. And that is a profound failure of our medical system, that we've made people worse diagnosticians than they were to start with. And I think that's something that all of us have to pay attention to really listen. Third is to don't assume. Now, assumptions are a big part of what we learn in medicine. We look at a patient and we decide, are they sick or not sick? Do they need my immediate attention or can they wait a little bit? But assumptions are also harmful, and they may not be correct. The case of Sandy, people assumed, right, that she was this middle-aged woman, nothing going on, and therefore her diagnosis was missed. But at the same time, you can also miss things like which patients would want to partner in their care. A few months ago, I was giving a talk, and a woman at the back of the room stood up and asked me, what do you see when you see me? Now, I don't know how to answer this, right? She was in her 60s, and so I didn't know if I should say a young woman, an old woman, probably not the old woman. But also, she was about my height. I'm 5'2", and so I thought maybe a short woman, maybe that'll be fair. But I didn't say anything, and she looked at me, and she said, well, I'll tell you what you see. You see an old woman. You see someone that if you let me talk, I'll just keep talking, and I'll never stop. And I know that's what you see because that's what my doctor sees when he sees me. And that's why my doctor never listens. And it's so profound because it's true. I'm sure her doctor took one look at her and said, you're just that type, to keep going. But you know what? She was the founding dean of our nursing school, one of the first nurse practitioners in the nation. And of all people who knew a lot about her own medical care and wanted to be a partner in her care, it was her. So that was such a profound lesson to me of just, here are the assumptions that we make, but try not to assume because it could lead to bad things happening later on too. All right, quickly, 5 tips on telling the story. And this, again, telling the story for yourself, to yourself when it comes to who am I in an application, but also telling the story when it comes to broader things like advocacy and journalism too. So the first thing is to start with why. I keep on going back to this because it's so important. Starting with your mission, understanding why you're doing what you're doing, so critical, right? Simon Sinek, who gives this wonderful TED Talk, last name S-I-N-E-K, he talks about why you have to start with why. And he says, there are companies like Apple, right? They don't start by saying, here are the specifications of this thing that I make, and that's why you should buy it. He says, here's why Apple is cool. Here's why owning it is cool, right? You start with the why, not the what. And that really applies when it comes to your personal statement in your interview. You are very accomplished. You've done all kinds of different things. It's very difficult for an admissions officer, for example, to weigh different extracurriculars against each other. I mean, how do you weigh one extracurricular versus another? How do you weigh 5 versus 10? Like, you can't really do that, right? So if you just put out, here's my verbal diarrhea, and here's all these things that I've done, people will look at you and be like, well, that's what you've done, but who are you? It's much more powerful to connect the things that you've done in some kind of cohesive story and say, this is why I'm driven to do what I'm doing. This is my passion. This is my goal in life. This is why I'm here. This is why I'm here in front of you. Start with why. Second, tell a good story. Easier said than done. If I knew how to tell a good story, I would be, I would be the best writer in the world, right? The best communicator in the world. But telling a good story really is so important. And it's not something that we in medicine really have any training in doing. Actually, I think doctors are very bad with learning how to listen to stories and how to tell a story. So learn what journalists do. Read op-eds, read journal articles, also I would encourage you guys to read short stories and read fiction because they're really good stories, right? And the elements of a good story include things like painting a picture, getting the person there with you so they can feel your emotions, right? And every story needs to have a narrative arc. It can't just be, here's what happened, period, on this one single day, and that's it. And that's why I'm in medicine. That doesn't really make sense. You didn't just come here all of a sudden. If I asked all of you, even what is your journey in arriving here at this conference, you would say, well, something happened, right? You found out about the conference, you're already motivated about medicine, you wanted to learn more. I mean, there's some kind of story to it. A narrative has to have a beginning, a middle, and an end. And so you have to at least tell your journey. And that's actually really powerful to say, here's who I was, here's what I did, here's how I changed, here's where I am now, here's who I am. That's why this all makes me who I am. So make sure that your story really incorporates those elements. And sometimes that element of surprise can be helpful too. I'll go over the rest of these fairly quickly, but related to people's lives, maybe less true for getting into medical school because everything that you do should relate. But everything else, think about what newscasters do when they talk about why you should care, right? They don't say, oh, 6 people came down with foodborne illnesses. They say, find out about how you can avoid foodborne illnesses, right? Here's how you can protect yourself. So think about how you can relate it to other people. Use an analogy if all else fails. Chinese culture, we have a ton of stories. So using these stories can help to illustrate your own story too, if that's something that people just don't seem to be getting. And then at the end, make it count. Aim for impact. If it's your personal statement, it should end with it shouldn't be obvious like, this is why you should admit me to your medical school, but it should have some kind of impact of, this is why I will be a good doctor. This is why my experiences have led me to where I am now, and this is why I am the person you should choose, right? I mean, it shouldn't be negative, like don't choose anybody else, but it should talk about what is the impact you're going to have at the end. And then if it's an advocacy, have something at the end of, this is what I've done, this is why this organization is important, and this is what I want you to do about it now, right? This is the impact that you're going to have about this too. So tricks and pitfalls, thinking about your target audience, fairly obvious, but less obvious perhaps is to learn from others. This is Diane Rehm, who I had the pleasure of meeting in the process of talking about my book. She hosts a very popular radio show on NPR, and there are master clinicians who are very good at getting the story, but so far in medicine, we've gone away from this apprenticeship model where we learn from really good doctors and we learn from great researchers and great scientists, but not necessarily good doctors. And so I encourage you to find people outside of your field. They don't have to be great doctors for you to learn from them. In the same way that you don't have to do extracurriculars in your field. You could also do extracurriculars in some other field. In the same way, identify people who are great journalists and lawyers and learn from them. And then if you're stuck, brainstorm the issue, listen more, and then you will get the story. In the case of Nick, I mean, he was so persistent in getting the story, and that one story of Johanita, that stays with me the rest of my life. I heard it, and it stays with me, right? Because that's something that really appeals to who I am, what I care about. And then really important to practice, practice, practice. We think about these other skills that we do. If you're learning how to suture, in medicine, right? If you're learning how to do an OChem equation even, you would practice that. You practice for your MCAT. So why not practice these very important skills? You may not be very good at telling your story now, but you will get better. So remember that this is a skill that you really have to practice for. Well, so what does all of this tell us? Well, hopefully I've been able to convince you somewhat that the narrative is actually really important, that you have to really listen. And ultimately, I believe that this is how we can make a difference in our healthcare. I hear all the time from students and physicians and people in general that, well, there's too much to be done. The system has to be changed. It's not me, it's the system. But who's the system? Right? If it's not all of you, as students, future health professionals, we're all patients, we're all caregivers. If it's not all of us aiming to make a difference, then who is it? I believe that all medicine ultimately is personal, that medicine is about medical care. It's the relationship between you, the patient, and the provider, or you, the provider, and your patient. And that's where change and that's where reform has to happen. Even if you can't change the system, you can change yourself so you can be a better doctor. You can change yourself so you can be a better patient too. And so I do think that you will get better. You have to practice getting and telling the story. And I do think it's a gift that keeps on giving. It's something that helps your patients and something that assists with both national and international advocacy and with your own life and personal statement and just keeping true to your ultimate mission too. So every story, again, has a beginning, middle, and an end. So I want to give you the end of our 3 stories that we started with. So Jerry, the car mechanic, he's doing just fine. He got over all of these random infections and other things, and he's doing fine. Again, he still feels lucky that he's alive. And I don't want to discourage him and say, you actually didn't get great medical care, but it's something for us to keep in mind that there is a cost of overtreatment, just as there is a cost to undertreatment as well, that things could happen altogether. Just as we get too much care, we also have people who don't get any medical care at all. And we have to address both of these issues together because it's the same spectrum or it's the different ends of the spectrum of the same problem, actually, that we're misusing medical care, misusing resources. Danielle, the college student, she's fine. She doesn't have much trust in the medical system. I don't think she's going to go back to the ER for a hangover, but she's doing just fine. As for Sandy, the school teacher, why tell her story? Because she's the reason I do what I do. Sandy was my mother. And I was a second-year medical student when she began telling me that she was having all of these vague symptoms that she couldn't explain. And I knew as soon as she called me that day, I just knew that something was really wrong because she never called me about anything. She never called me about, she never wanted to worry me. She never went to the doctor. So for her to call me and say, I'm worried, I was really worried. So I went home to LA. I was in St. Louis in medical school at the time, and I went home to LA and I would go with her to her doctor's appointment. But her doctor she would say to me, don't speak up. Don't tell my doctor. Because she was so afraid that her doctor would see her as the bad patient, as some patient who always complains if I spoke up. And you know what? I think about this every day. And I think about, well, what if I did speak up? What if I did insist on telling her story? What a difference that would have made. And maybe it wouldn't have, or who knows, right? It's difficult to say in hindsight. But I just encourage you that if you think that one person can't make a difference, or if you think that one story can't make a difference, to keep my story in mind. Because this is something that I wish every day that I knew how important it is to advocate for yourself, how important it is to speak up, but also how important that single story can be. And so with that, I want to give you my contact information to encourage you to find out more, if you do, from my book, When Doctors Don't Listen, but also to really just applaud all of you for coming here. I'm, again, incredibly inspired by your stories, your mission, and I encourage you to stick true and stay true to who you are, what you believe, and to the idea that the story is so important. Practice telling the story, practice getting the story, and I have every faith that all of you will be incredible doctors, incredible health professionals, and whatever else you choose. Thank you very much. Thank you. So we have a few minutes for questions, and I don't think I'm the most intimidating person, so feel free to ask me anything. And then afterwards, Diana is going to be helping with book sales, if that's something that you're interested in. I'm happy to personalize them for you. Any questions that I can help answer? Yes?
You said that you were a journalist for a while. Is it before your your medical career, or after your medical career?
During. It was during. So I took a lot of, this is why I don't like the question, right, of how, this is not the question you asked, but some people will say, well, how did you get to work for the New York Times, or how did you get to do whatever, right? I was a Rhodes Scholar, I worked with the WHO, I did all this stuff, but it wasn't planned out. I never said going into medicine. I took 4 years off in the middle of my medical training. I took 2 years off in medical school, 2 years off after medical school. That's not a typical path. But I also didn't go into medicine saying, I'm going to do this, right? So when I was in medicine, I actually got disillusioned. I thought that we're doing so much to our patients, but we're not looking at the bigger picture. And I thought that journalism would help me figure that bigger picture out. That's why I did it. That was my mission, right? It's a very different mission to what I have now, but in the process of doing that, I learned a ton. I don't regret it at all. But I also realized that that's not the way that I need to make a difference, that ultimately my heart is in patient care and that I have to take care of my patients first and foremost. And that's how I'm going to make a difference the most. But that I'm going to keep writing. I mean, I've kept writing, and I have a blog. I keep writing on a number of subjects. And being a journalist taught me a lot about storytelling and learning that. But it was not something deliberate that I planned in advance, if that makes sense.
Where did you go, like, during your journal, like, career, journalist career?
So I worked for the New York Times, and I was mainly based out of East Africa. Yes.
What was one of the biggest challenges that you faced when you were pursuing medicine, and how did you overcome it?
So growing up, I had a lot of shame. I talked about this earlier, so for those of you, hopefully it's not a repeat, but I had a ton of shame, and here was my shame, my sources of shame. I stuttered really badly. I could barely get words out most of the time. I would go to my classes, and you know how on the first day of class, teachers would ask you to raise your hands and say your name? I always pretended I was sick because I didn't want to say my name. Once I was called on to do a question, and I poked a pencil into my leg so that I could be at the nursing office. I mean, this was how severe of an impediment that was to me. And I was ashamed of being an immigrant when I moved to the US. I was ashamed of so many things that were part of my identity. And one day, I looked at myself in the mirror and I said, I can't do this anymore. I have to be true to who I am. And that's why I made a commitment actually to total transparency. Somebody was asking me in another session, I know this is not your question, but somewhat related, somebody was asking me in another session, well, what do you say to patients to help them understand that you're there for them? This is what I say, and this is really atypical, so I know that not a lot of people say this, but I'm trying to get more doctors to do this. I say to them, hi, I'm Leana Wen, I'm your doctor. I do not accept any money from drug companies or device companies. I never have, I never will. That's very important to me. I also don't get any more money from doing more tests on you or more procedures on you. I also don't make any less money for ordering procedures and tests on you. So then you know that everything that I'm doing is in your best interest. I am only here for you. And I will answer any questions that you want about me because you're going to be so vulnerable for me. I want to be just as vulnerable for you. I do this. I believe in total transparency. All my information is available on a website. People can find out my husband's name, my birthday, whatever you want, it's all there. Because I believe that my patients, they're so scared when they're coming to see me. I'm asking them to reveal everything. They're getting naked in front of me. They literally, right? Well, I believe that I should be transparent back. So that was the biggest barrier that I faced with all this shame. And I just decided, I'm going to eliminate it. I don't care. If you judge me because of things that I had to overcome in the past, and then that's your issue, it's not mine. Does that make sense?
Yeah.
So sure, my final question.
Just going back to the patient narrative, I mean, from what you've said, I think maybe the issue is poor communication from the doctors. It's not that you shouldn't ask any questions, but it's the way you ask the questions. It's not one size fits all kind of situation. I think it's more a sense of being empathic with the patient and knowing the patient as an individual. I'm saying this possibly because of my my background as well. I'm not from America. I'm not a local person, but I've had the opportunity to work in a healthcare profession where I've had to ask patients questions personally, and I think the general feedback I get is my doctor doesn't listen. I didn't understand what that meant until I went to see my own doctor. I don't normally go to my own my doctor regularly, and the experience that I had wasn't a pleasant experience because I just felt he had like, right, these are the symptoms you've got, so this is what I want you to do, right, as opposed to what do you feel. And as a healthcare professional, I felt bad, right, about that situation. So I suppose maybe the question I'm trying to find out is what support is out there, because we get this every time you hear doctors don't listen.
Yeah.
what support is out there for someone going in to a
Right.
profession?
That's actually exactly why I wrote my book, because I wrote my book, When Doctors Don't Listen, initially for patients. I mean, I think it contains a lot of things that are applicable for us learning as health professionals and health professional students, but actually it's meant for patients, because patients don't really understand that they'll be interrupted in 10 seconds, right? Patients may not know these pressures that doctors are under. It's not their fault. I mean, I'm not saying that patients have to overcome this themselves, but rather that they should be aware that this is what's happening and therefore know the strategies for overcoming it. So for example, in my book, I talk about how patients can tell a better story. Because if you tell a better story, that kind of forces the doctor to listen. Or if your doctor has all these pagers and cell phones that ring, what do, right? This is also part of this book, that it tells you what are the things that you could do. And then when do you have to switch doctors? Because at some point, maybe your doctor just isn't doing right by you. And that's something that I also learned the hard way with my mother, that sometimes you just are not going to get anywhere. So when do you know when that time is there? But anyway, we are running too close to the end of our time, or at the end of our time. I want to thank you guys again, and to say again, my book is available, and I'm happy to personalize them for you. But also, I want to wish you all the best of luck in your future studies and your career. Thank you very much.